Hi, everyone. Sorry, we're having a few technical difficulties here, but I think we've got it worked out. So hi, everyone. Welcome back. My name is Jason Van Medding. I'm a researcher at the University of Florida. I've been your host for the past couple of weeks. I'm here again with Darian Alexander Williams. We're co-hosts on a podcast called Disasters Deconstructed. And we're so pleased to be back with you again today for another climate-related discussion over lunch. And we have some amazing guests with us again today to speak to issues related to climate change with a focus on Florida. The point of this series really is to disseminate knowledge to inform decisions on how to move Florida forward with the best science.
And thank you all for joining us in this conversation. Like Jason said, I'm Darian. I'm a researcher at MIT, originally from Jacksonville, Florida. And as we get started, we just want to thank the Florida Climate Institute for organizing this event and this series, along with co-sponsors the Florida Sea Grant and the UF Office of Sustainability. So our conversation today is about climate, health, and equity. And so climate change presents ever-increasing challenges in the sphere of public health, and exacerbates existing inequalities and injustices already apparent in our public health statistics. But today, we consider how these issues of climate, health, and equity intersect in Florida, and what the work of the future looks like on these matters. And so we have three very special guests joining us today for this conversation.
And so wherever you're watching this stream, we do invite you to engage with the discussion. We'll be monitoring the chat across whatever platform you're on and bringing in your questions to our speakers wherever it's possible. So I want to begin today by introducing Sadie Ryan, who is with us. Sadie is Associate Professor of Medical Geography at the University of Florida and the Director of the Quantitative Disease Ecology and Conservation Lab, where she focuses on medical geography and ecology at the human-wildlife interface, particularly where it pertains to disease ecology, conservation biology, and wildlife management. So welcome, Sadie. Thanks for joining us.
Thank you very much for having me.
And also joining us, we have Dr. Naresh Kumar. Naresh is Associate Professor of Environmental Health at the University of Miami. His research and teaching are dedicated to prevent and manage environmental disease burden, and he engages communities in prevention measures through personalized real-time environmental risk surveillance systems. Welcome, Naresh.
Sorry, I've got you on there, Naresh. Welcome.
Nice. Delighted to be here with this.
Thanks, Naresh. And finally, we're joined by Dr. Lisa Platt. Lisa is Assistant Professor at University of Florida's Department of Interior Design and my colleague at the Florida Institute for Built Environment Resilience, FIBER. Her work is driven by the concept of designing and building proactively adaptive and human-centered environmental systems. Thanks for being with us today, Lisa.
Thanks for having me. It seems as though my camera is not cooperating, so apologies for that, but it's good to be here.
That's quite okay. We'll work through it. I think the stream looks okay to me, and everybody's camera should be okay, except I know you're dealing with bandwidth issues, Lisa.
Great. So now we're going to hear from each of our guests about their particular perspective on climate, health, and equity, maybe some work that they have done, are doing, are thinking about doing. And they're each incredible researchers, and our discussion today is going to be so rich. So I'm so excited. And maybe we can start off by handing it over to Dr. Sadie Ryan.
I believe that is not my slides, but that's okay. There we go. Hi, so I'm Sadie Ryan, and I am a professor of, an associate professor of medical geography in the Department of Geography with a joint appointment in the Emerging Pathogens Institute. And recently, my group and I have been focusing on questions of vector-borne diseases, so mosquito and tick-borne diseases particularly, and thinking about this in the context of a changing world. And so when we think about the changing climate, Florida is a really interesting lens on what's going to be, the future of this. And so on this first slide, I'm just giving you some little vignettes of a lot of us remember the top tip, toss, and treat that happened, this big campaign that happened when Zika showed up in Florida. And that was a really nice example of public health communication that people really grasped and understood in context of preventing mosquito-borne diseases. What we see on the bottom right is a global picture of what's going to happen to the climate across the globe with global warming and essentially the surface temperature change across a 100-year projection. On the left at the bottom, what I did is took some data from the Climate Impact Lab, and I'm showing you what's going to happen in Florida as the annual average temperature, so that's taking a lot of variation and smushing it, under two different representative concentration pathways, that's these RCPs, where RCP 4.5 is assuming we're going to do some mitigation for climate change. RCP 8.5 is what we call business as usual, and so that's saying we're not doing mitigation, essentially. And this is projecting what that average annual temperature in Florida is going to look like over the coming decades. So as you can see, we're going to see a rise of a few degrees Fahrenheit. And so when we think about why am I talking about this, very, very broad scale average temperature question, when we think about the biology of organisms, what drives that? So temperature drives these biological processes because basically we're all just bags of chemicals. And so for mosquitoes, this is going to drive the processes like biting and growing, laying eggs, developing the larvae. And we see a curve in response to temperature that looks a bit like this sort of right bumped curve, because at a very low temperature, nothing starts. And then things speed up with temperature. We remember this from high school chemistry. Our enzymes and proteins are just like this. And things get optimized at a certain temperature. They want to take advantage of that speeding up of processes. But at some point, it's going to hit a lethal maximum. Essentially, proteins start cooking. And so it breaks down really fast after that optimum. So you get this very, very clear curved response. That works when we put it into a transmission equation for diseases, because we're including all of the life history of both that vector, the mosquito or the tick, and the pathogen, and they're all responding to this temperature in a similar way. And the pathogen and the vector, so your bug with its bug, is a very tightly coupled relationship, and they fly around in the environment, so they're very responsive to that environmental temperature. And so as a group of scientists, we've looked at this for various different diseases, and here are two dengue thermal curves. And so dengue is a flavivirus disease. We have two vectors for it here, Aedes aegypti, the yellow fever mosquito, and Aedes albopictus, the invasive tiger mosquito. And what we saw with this is that the tiger mosquito has a slightly cooler curve than the Aedes aegypti yellow fever mosquito when we look at that same dengue pathogen in them. And so we're going to see some slight different impact of that if we think about it in terms of climate. When we looked at Zika, so some colleagues went into a lab and they infected that yellow fever mosquito with Zika and saw that that temperature curve looked pretty similar at the optimum, but it seems to need a bit more warmth to start transmitting at the lower end. And as a geographer, I want to know what that looks like on a landscape. And so we put some of that on global maps. And this is talking about in a generation from now, so in 2050, what are the thermal limits on Zika going to look like across the globe? And so this is taking monthly average temperatures under these different climate change scenarios and saying how many months of the year is a certain area suitable. Now, all that means is if the mosquito and the pathogen show up, it can take off, right? So it's saying it's not excluded by colder temperatures or overly hot temperatures. But we probably want to think about this more in the terms of risk. And so what we did in this chart is we took the global burden of disease regions, so a sort of international way of thinking about how regionality exists on the globe, and looked at how many new people are going to be exposed or at risk of being exposed in a generation, and which regions are going to be affected under these two different pathways of future climate. So we've got 4.5 at the top and 8.5 at the bottom. And so we have these global ideas of what's going to happen and how it's going to impact different regions. What happens when we look at Florida? So in Florida, over the past 10 years, these three flaviviral diseases, so these arboviral diseases, have been present. In our very recent memory is that massive spike in Zika, and more recently we've seen an uptick in what's on here as WNV, West Nile virus, which is transmitted by Culex mosquitoes. But what we see is there have been cases of these diseases across the past decade. When we zoom in on this, where are these cases coming from? So Florida in 2015 had about 20 million people in it, and in 2021 we think we're going to cross about 22 million. There's a lot of people in this state. What I'm doing here is I'm taking some climate modeled for North America at a 1 kilometer resolution so we can really zoom in on Florida. And I'm using a more recent baseline to think about this. So sort of 2010 is roughly, if we think of the climate normal period ending in 2010. And I'm going to show you a bit of futures for one of these diseases for the sake of not taking the entire time of this pod. So if we look at this graph on the right, what this is dengue cases in Florida across that 10 years, and the red ones are locally acquired cases. The gray ones are imported cases. So what this is telling us is that cases of diseases can come in and they can establish and we can get local transmission. So this is a little alarming, right? And so if we look at how many months of the year are different parts of Florida suitable for that to occur on this sort of baseline temperature, what we see is we see this gradation, right? We see that for about 7 or 8 months of the year, even 8 or 9, down in the Miami area, we have, lots of suitability. We have these high population centers. And as we move north, it gets slightly cooler on average. But we're seeing that even all the way in the north of Florida, we have 4 or 5 months of the year where it is suitable for transmission of dengue to occur. This is monthly average data, right? When we look at West Nile virus, we've had cases every year across the past decade, and this is Culex mosquitoes. And in particular, we're looking at a case where it's Culex quinquefasciatus, or quinks, which we know are present in Florida. There are multiple Culex species in Florida, and many of them could transmit to West Nile, but we only have enough data to understand the thermal curves so far on these ones. And so what does that look like? Well, it looks similar to the dengue risk, right? So we have more months of the year are suitable in southern Florida, and as we move north, we see that fewer months are suitable for that disease to show up and transmit. But everywhere in Florida, there is some months of the year where this could show up and create local cases. And so I talked about Zika. Zika was this one that arrived. It was a new virus. It took advantage of the mosquitoes that were already here, or Aedes aegypti mosquitoes. And it's the one that has that slightly warmer bottom temperature before it can start. And we saw a lot of cases of Zika, and some of them were locally transmitted. And so what does this look like? So at the baseline, the climate baseline, when this showed up, so sort of roughly in the 2015 census population, which I have here, 23 counties were susceptible to that suitability for 6 or more months of the year. And that was about 12 million people who were living in those areas of that condition. And so as we look to the north, we see that this is definitely because it's a warmer transmission, there are fewer months of the year susceptible as we get further north. However, if we look at this under climate change scenarios, so projected future monthly climates, what we see is that 6-month line starts to move north through the state. And so this is in a climate mitigation scenario, that RCP 4.5 I alluded to at the beginning. And then this is if we have our business as usual, we see that that sort of 6-month suitability boundary moves all the way to the north of the state. And so this is sort of a way of mapping what we know from the biology onto what we know about climate futures to think about how we can leverage this kind of, sort of exquisitely tight coupled vector pathogen combo for thinking about future planning. Now, we have to remember that this is all in the context of also human behavior and other environmental factors that promote the existence, the breeding of the mosquitoes, the introductions of pathogens. And so this is really just giving us that sort of thermal suitability background risk. And so what is this going to mean? Well, if we see an increase in the number of places that have suitability for more of the year, it's going to increase the burden on vector control districts, on vector control activities, and that costs money. It provides us a map to think about where we need to anticipate these shifting boundaries on risk and where we want to add more surveillance and screening. And again, that's, a financial decision. It also tells us that we need to improve our point of care training on the recognition of things like novel arboviruses. And these 3 arboviruses I've talked about today don't have vaccinations that are widely available to everyone. There aren't sort of preventative methods for them. It's all about palliative care and what you do once it happens. And then obviously prevention. How do you avoid it starting up in the first place? Because many circumstances promote vector habitat. We talk about things like post-disaster issues with standing water, with trash that can hold standing water that isn't cleaned up fast enough, with people being outside helping clean up and getting greater exposure. And so in those thermally suitable areas, we need to think about this and increase that awareness and monitoring. And as I mentioned at the outset, with Zika, we started to get a lot of that great public health communication about tip and toss and be aware and figure out sort of what around your home is suitable mosquito habitat. And so I will leave you with that vignette about sort of my work on mosquitoes and climate change. And I'm excited to carry on chatting with everyone.
Thank you so much. That was excellent. And next up, we have Dr. Naresh Kumar. I'll hand it over to you.
Thank you, Darren. Okay, Dr. Ryan laid a very nice background of the link between climate change and vector disease. However, the connection between climate change and disease does not stop just only to the vector-borne disease. So in this presentation, I will walk you through with some of the basic ideas about how is climate associated with various health impacts. Some of these are short-term effects, some of these are long-term effects. And what is this interplay between climate change, changing ecology, environment? And then I will point some of the example of the disease that we are likely to in the future. And of course, we experience them firsthand today. So to begin with, I'm Naresh Kumar. I'm a faculty at the University of Miami. And I do direct a newly established graduate program. We call it MSCH, Master of Science in Climate and Health. Okay, so in order to prepare for the health effects of climate change, first we need to understand what is the potential disease burden related to climate. So before I get started, I want to declare that I have no conflict of interest in the research motivation, conduct of this research, or any data that I collected or analyzed or interpreted. I don't have any conflict of interest. This work in part was supported by the University of Florida, one consortium. They provided a nice data set for some of the data I'm going to show today. And part of this research was also supported by the NIHS. All right, so to begin with, climate change. There is a direct and indirect connection between climate and change. Some of these effects are related to climate are short-term, and some of these effects are long-term. In the figure that you are seeing on screen, I classify them from left to right. Some are long-term effects, which, as we already know, the global warming trends have been intensifying over the years. As a result of this, you will definitely see some of these anticipated changes. For example, sea level rise, increase in temperature, drought and precipitation patterns. Related to that, on the other hand, you will see that I'm also describing changes in ecology. For example, kind of bioaerosols, I meant to say mold, pollen, microorganisms that are airborne, we call them bioaerosols. So intensity and the concentration of these bioaerosols is likely to intensify. And whenever these changes are taking place, they will last there forever. But these are slow or gradual changes due to changing climate. On the other hand, if you look at the right-hand side, due to the positive feedback loop of climate change, you will be seeing these extreme weather events, such as forest fire, pollution transport, Saharan dust that we see firsthand in Miami, or extreme weather hurricanes that we witness firsthand in Florida, snow blizzards, red tides, drought, flooding. Now, any of these boxes, examples that I present here, they are just some of these key manifestations of changing climate. But related to each of these, there are anticipated physiological responses, in other words, the health impacts. Some of these health impacts are because of these gradual changes in the environment, and some of these changes are due to these simply extreme weather events. Let's take an example of forest fire. We are seeing the highest intensity and frequency of forest fire for the past 2 years, including the images and the video that you saw in California. Related to forest fire, of course, you will see unintentional injuries firsthand. But on the other hand, the pollution transport, people who are directly in contact with these areas, they will be also exposed to air pollution. Likewise, we have seen the highest intensity of dust storm in the eastern part of the United States, including the Caribbean islands. And related to that dust, of course, as we already know, dust does carry fine and coarse particles, and they are implicated in various diseases. Likewise, hurricanes. Health impacts of hurricanes have been well studied, but many of them do go unnoticed, and I'm going to walk you through with one of these very simple examples. Drought, on the other hand, when we have in some of the area rain deficit or precipitation deficit, in those areas it's going to directly impact nutrition, and those nutrition deficit will be impacting nutrition-borne disease, for example, malnutrition. On the other hand, in Miami area and south part of Florida, we are seeing these king tides. So you have relatively higher moisture content year-round, increasing temperature. It is changing the kind of microorganisms we see airborne all the time. As a result, some of the infectious disease that you don't anticipate are occurring. For example, non-tuberculosis mycobacterium. We are now seeing the highest incidence of NTM in South Florida. So how do you establish these connections? You need large-scale data set, retrospective data sets, in order to guide future projection. As Dr. Ryan showed you, once we know what is the connection between exposure to a given disease, then you can plug in these numbers into future scenario, and those future scenarios can guide us in how to prepare for some of these anticipated disease. So per se, climate change, you have the short-term impact on the environment, then you have also the long-term impacts, and related to that, you will see what type of disease you are going to see in long run. I call them infectious disease effects. On the other hand, you are seeing these extreme weather events, and they are largely related to acute effects. But some of these effects can also persist for days, months, and even years. So let me show you one example of my research. In this research, I show you that I acquired from Florida Alliance, where I identified the number of hospital visits. One Florida, by the way, is a consortium of all these healthcare providers in entire Florida, and does 75% of the population being served by these clinics. And all these clinics, this consortium, they transmit these data to this central facility, one Florida. And what we did was ask them to provide us all the cases of hospital visits in the emergency room or any regular clinic. And what I'm showing you here is 6 months before Hurricane Irma and 6 months after. And what we noticed was, after Hurricane Irma, on an average, there was 31,187 more emergency room visits 6 months after Hurricane Irma as compared to 6 months before. And among them, I also provide further classification based on the International Classification of Disease, allergies, and asthma. But think about the average rate of treating a patient who visits an emergency room is about $2,800. You simply multiply by this number, the healthcare cost just for the emergency room visit after Hurricane Irma was $87,000 million. That's not a cost. So in principle, we often overlook and miss the total burden of disease related to either the extreme weather patterns or many of the climate changing scenario. Another interesting example that I'm going to show you here is what you are seeing here is in case of asthma, there was about a 4-point increase in the clinical visit due to asthma. In case of allergies, however, there was about 4.36% decline 6 months after Hurricane Irma. How do you explain it? Am I stating that the allergy incidence declined after the hurricane? That's not really correct. The correct answer is the allergy burden in the aftermath of many of these events does increase. Think about any hurricane, flooding. You have water damaged building. As a consequence of this, you will be small. So how do you really explain the decline in emergency room visits or the regular clinical visits due to allergies? The answer is many of these data sets are underestimating some of the disease for which people don't seek healthcare. In case of asthma, however, on the other hand, it's a life-threatening condition. And for those kind of disease, you have no other choice. Either go to emergency room, or if you can get hold of a physician, you visit them. Consequently, many of the non-life-threatening disease do go underreported, especially in the clinical record. So the take-home message is, when we want to tease out the burden of disease related to extreme weather patterns or climate change, we need to factor in a variety of data sets and also critically evaluate if we are missing any of the disease burden. Just to give you one example, obesity and many chronic disease, we call inflammatory disease. So what's the connection between these increasing temperature and these chronic disease? Often we don't think about obesity, diabetes, any other chronic disease related to warming of the temperature. In principle, thermoregulation is one of the concepts. When body come in contact with higher temperature, it turns brown fat into white fat, and that white fat in turn invites more inflammatory responses. So if we plug in the number of, let's say, a climate scenario of any of the models, by 2050, average temperature increase will be taking place. In relation to that, you'll be seeing relatively more chronic disease. And we are still scratching the surface of this link between climate and health, because some of the diseases are very easy to understand and quantify, as Dr. Ryan, that vector-borne disease. We know that if there is more rain, if there is high temperature, of course, these are ideal ground for mosquitoes. But the small change in, let's say, 1.5 degree temperature, related to that, what's the change in the proportion of brown fat versus white fat? We don't know those things. Likewise, the example that I showed you on this screen is there is a severe underreporting of non-life-threatening disease related to climate, as well as the extreme weather patterns. So the take-home message is that we need a multi-risk factor approach in which we need to quantify what are the retrospective changes in the social, physical environment, and related to those environment, what amount of exposure is changed, related to those environmental exposures, what are those potential health impacts. And based on that, we can develop preparation and mitigation strategies. So the take-home message is that with regard to understanding the link between climate and health, we have severely underestimated disease burden of climate change and human health. So in order to prepare for mitigating the health effects of climate change, to begin with, we need to revisit many of these retrospective data sets, and we take a multi type of data sets. For example, in case of the more recent research on the health impacts of hurricane, we are using clinical record. We are also using the vital statistics, mortality and birth rate, but these data are incomplete because some of these cases do go unreported, especially for the non-life disease. So in order to gauge what is the precise burden of disease, you also need to screen communities who are impacted directly by the extreme weather events or by the climate change. So once we have the exact number, then we can quantify precise disease burden and then tie this into the healthcare costs associated with these disease. And once we have those numbers, then perhaps we can have more adequate strategies to prepare and to adapt to anticipated climate change scenarios. So I will stop here and I will be happy to take some of your questions and engage in the discussion.
Excellent. And thank you so much. And next, we will hand it over to Dr. Lisa Platt.
Thank you, Darian. And I am going to just turn my camera on to say hi and then turn it off because I don't want to distract anybody by the bandwidth issues I'm having. So I'm going to dovetail off of what Dr. Kumar and Dr. Ryan had said in terms of how do you actually model risk of infectious disease. Full disclosure, I am a systems science and systems engineer. That's my background. And before I worked at a university, I was basically an operational systems analyst for health systems in North and South America and internationally. And I only mention this because when it comes to community health research, I have a tendency to be a bit of a pragmatist, and I really attribute that to my background. So I'll just ask you to bear that in mind when I'm talking about the research that my colleagues at UF and Fiber and I are engaged in. And could I get the next slide, please? So the focus of my ongoing study is on analyzing health systems' defense and depth resistance to outside design basis risk. So what does that mean? Well, defense in depth basically refers to the layers of protection that any engineered or socio-technical system has to prevent potential harm from becoming an actual crisis, which is pretty important in healthcare delivery and public health. And this research also includes investigating the resilience potential of specific designed system interventions that are responsive to moderating human health hazards like infectious disease that are both known and unforeseen. And specifically, I use mathematical simulation models to try to evaluate acute and chronic infectious disease or conditions caused or intensified by a lack of adaptive health systems infrastructure, and how this can affect the long-term well-being of especially at-risk individuals in the communities that they comprise. And unsurprisingly, this process usually points to gaps in health resource parity or equity, whether through access or supply. And one of the consistent aims of this area of study, which in most cases endeavors to be applied research, is to try to identify those systems variables that can serve as levers of resilience through either proactive action or autonomous adaptive response to increase health equity. Can I get the next slide, please? So we can look at something like the phenomenon of, say, like inland migration due to climate change on community health resources, which is as we all know, an emerging concern in a state like Florida. In fact, there's been precedent research that supports that climactic warming and antimicrobial resistance of infection-causing bacteria are tracking basically in lockstep with one another, as indicated by the map at the bottom of the slide. And the realization that increased human migration impacts community infrastructure stability is certainly not a new idea, nor is the realization that migration patterns have a demonstrated effect on infectious disease and condition epidemiology. What is becoming a growing area of concern in the age of spillover viruses like COVID-19 and escalating antimicrobial resistance is the additional stresses that something like inland migration due to climate change will have on community infrastructure and health systems resilience, and how that might affect communities that are especially at risk of contracting infectious disease due to some sort of systemic disenfranchisement. So our fiber-based team has been working on funded research since this past July 2020 that analyzes the relationships between incident rates of MRSA hospital-acquired infections in the state of Florida. And we know MRSA is a big issue in Florida and other humid climates, and associated regional socioeconomic and demographic factors. And based on the preliminary results we've observed, that there are notable co-occurrences between factors like community populations that are over the age of 65 years old, higher incidences of housing cost burden and housing transients, regional population density increases, and localized occurrences of MRSA infections. And this suggests that strains in community infrastructure accessibility and adequacy might be related to contextually specific infectivity potential, which is something that is pretty much already supported by precedent research. But this approach to regionally specific data analysis and related variable identification allows for the development of context-specific predictive models that allow us to then simulate the potential performance outcomes of different types of infrastructure interventions and resource supply chain effectiveness on issues like community adaptive response to inland migration. Could I get the next slide, please? So one way we can approach this in a way that's really conducive to community stakeholder collaboration and consensus building is to use things like feed-forward models such as artificial intelligence informed systems dynamics. And this approach can be really useful in developing planning and intervention strategies meant to increase system performance reliability in complex human activity scenarios, like those regions prone to experiencing high levels of inland migration. Also, an approach to community infrastructure planning methods like dynamic systems modeling that includes the collaboration with key at-risk population community stakeholders really helps to ensure that individual user responses to possible outcomes achieve those high-level planning goals identified for health system resource strategy implementation. And using this kind of low threshold for learning and high ceiling for analysis approach has already been adapted for community engagement use by other academic institutes around the world. This type of analysis allows research teams to design forecasting models based on community subject matter expert input that not only facilitates community buy-in, but actually also improves the model validity. Could you, next slide, please? Thank you. So another critical aspect of mobilizing an effort like collaborative systems modeling is to set really clear parameters for your initiative. So for example, research that's either underway or under development at Fiber includes analysis of issues like understanding the regional impact of preventable health risks and improving health outcomes and systems parity in socioeconomic vulnerable communities. However, we're not trying to do all of it in equal measures under the same source of support. So your community health systems analysis areas of focus need to be broad enough to be valuable to a cross-section of community stakeholders, but should also be targeted enough to see observable patterns in your model, identify where your levers of systems impact exist, and also be able to ascertain what systems or system elements might offer those greatest potentials for control of reliably acceptable outcomes. And I'm not going to say good, because sometimes in systems improvement, good is a pretty high bar to achieve in a reliable fashion. Could I get the next slide, please? So in conclusion, some key insights working both as a consultant and a researcher with collaborators that really seem to do systems well. I've noticed they usually adopt some practices that are effective in any type of public health system operational advancement or community health improvement. And that is to start out with identifying those high impact, low effort initiatives, or what I like to call the just do it action items, like facilitating community engagement and root cause issue identification, integrating low threshold, high ceiling predictive frameworks, even just using theoretical data, and systematically pinpointing the low hanging fruit opportunities for health systems infrastructure and community infrastructure improvement. Additionally, they identify high impact and high effort initiatives for ensuring long-term system operational resilience, such as establishing current state glass box performance metrics conducive to long-term community health performance monitoring, really committing to data transparency, which basically backs up the first point, and ease of information accessibility, systematically using community health infrastructure performance forecasting for iterative community health systems improvement, and integrating human-centered, context-specific, reciprocal state of the system communication design. So that basically concludes my presentation, and I'm happy to join in the conversation.
Thank you so much, Lisa, and thank you to all of our presenters today. So much to take in there, and it's been a really interesting to look at this intersection between how we deal with public health risks generally and the climate crisis. And so we also know that climate change impacts are already impacting oppressed people the most, right, around the world. And so the question is, how do we develop and prioritize strategies to fight for equity and justice in public health in the future, specifically in Florida? So what we want to do now is open up this discussion. We have maybe 15 or 20 minutes left now, and we want to explore some of the issues that we've heard about from Sadie, Naresh, and Lisa. And again, anybody watching, we'd love to hear from you in the questions. You can just drop anything you want to say into the comments.
And maybe just to start off, generally, and maybe it's a little bit meta to be asking this on a web show where we're having this conversation with many different voices from many different perspectives. But how do you envision policy being informed by research, or like what are the main ways that work in your field sort of lands and reaches a non-scientific community? Sadie, you mentioned this amazing campaign really early on in your presentation. Naresh, you talked about the importance of multi-factor approaches and the importance of screening, especially around disaster events. And Lisa, I know you mentioned including community health systems. Like, what does that work look like? And how do those pieces come together to address equity and injustice?
Well, I'll take a stab at this, and I'm interested to hear what Sadie and Naresh say. What I typically say to community health systems and public health officials when I've worked with them in the past, and certainly when I collaborate with them on research, is that I'm just an engineer. All I can do is build models, and they're really the subject matter experts on their own system. And this includes community members who are working with them. That, I think, is really, I'm hoping to see more of that trend going forward, of researchers really engaging with community members, because just from merely practical point of view, if you're not reaching out to at-risk communities, you're really missing critical information. And so although your model might produce reliable results, they could be reliably wrong. So that's one of those, again, one of those phenomenons that there's a lot more ability to engage with diverse community groups and doing this research. So that is my hope, that we're going to see more and more of that.
Sari, do you want to add something?
Yeah, so from my perspective, when we go into work with stakeholders, so thinking about, if we want to present this to someone who's going to enact a mosquito control campaign, for example, the very first question I would ask going in on a project like that is, what decisions can you make? And, what tools do you have available and what lead times do you need on those decisions? And so things like, do you go out and survey larval environment at the household level? Is that something within your capacity? Or is that just, budgetarily out of the question? Do you get to make decisions about when to fog and how far ahead of time do you need to allocate the budget for that? And so thinking about, can we create the kinds of exercises in modeling using data that's already available that link to decisions that actually could be made is so fundamental to being able to enact any of the, the utility of the science we have. And so a lot of times it's about, can we have a stakeholder meeting right at the front of this project if we're thinking about getting into the applied realm. On the other side, you mentioned the communication of risk question. That's been an interesting sort of journey for me as well, which is that policymakers want to know how much money it's going to cost. They want to know how many people it's going to affect. And so translating these sort of, highly specialized biological and mathematical models into something that can be cast as a risk estimate that somebody can, take to their constituents is also super important. And then how that then reaches the entire community is another great question to ask when you're in that very first stakeholder meeting. Is this going to be broadly applicable, or is this only going to, reach certain other decision makers? And what tools can we do to advance beyond that?
So from my perspective, when I think about research guiding policies, I just don't restrict this to one stakeholder. It has a kind of multi-stakeholder impacts. Let's take an example of pediatric asthma, climate change, right? Year-round, you have very high pollen counts. Especially in South Florida, you have year-round very high mold. On top, you are adding, let's say, king tides. Now, screening communities, what you are seeing in the lab, for example, or the clinic, screening the individuals, where do they come from? What kind of condition they are present? How often they are impacted by king tides, right? So what are the concentration of mold and spore types in those areas vis-a-vis those who are not that much severely impacting? So from baseline teasing out, people who are living and impacted by these king tides, the burden of asthma, morbidity is this much. Now, when you have that information and clinicians know about it, you have to train clinician too. They in itself can tell that you need to make some simple modification in your home, regulating humidity and temperature, for example. If you can just simply control these two factors, you can reduce asthma morbidity dramatically. Now, that's number one. So you're directly engaging through clinician your patients. Secondly, with regard to this research, housing design, what kind of air conditioning system you need to put in place in future so that the future housing conditions don't create these conditions. For example, if you are putting fiberglass kind of ducts in the home and you are anticipating king tides, increasing humidity and temperatures, they will suffocate, and there's no way unless you replace these your ducts to remove this mold. So asthma morbidity will keep on rising. So likewise, you can have policies with regard to other decision makers too. So you directly engage public, you directly engage clinician, you directly engage the housing or the housing design expert, and also simultaneously the building material companies as well. So when you learn from research, it has a multi-stakeholder impacts. The fundamental question, however, is most of this research is just buried in these e-refereed paper. That doesn't translate to the public. That doesn't translate to clinician. And one of the goal of the doctoral program that we are, this MSCH program we are starting, we want to train our clinician firsthand to begin. And this is where you have the highest benefit from your investment, because they are the one who are going to engage these people. So training your future manpower, whether it is clinician or engineers, to understand what these issues you are anticipating down the road in order to mitigate the health impacts of changing climate. And likewise, you can extrapolate this to virtually any disease. I just took only one simple example of asthma.
Thank you.
I think we lost Naresh for a second. Sorry. So I want to, hopefully we get Naresh back, but Lisa, I want to ask you a question that links to climate change. So, like, do you think that people in Florida are aware of how diseases will interact with climate change? And how should policymakers be working with science on this front?
That's a great question, Jason. Thank you for that. To answer the first part of the question, no, I don't think that there is a great awareness of the role climate change is having on infectious disease, whether that's the vector-borne diseases that Sadie discussed or antimicrobial resistant bacteria conditions that are rising pretty, as I said, pretty much in step with climatic warming. So I think one of the ways that certainly communities and policymakers can work with researchers is, again, in understanding how transdisciplinary teams can work together to help find solutions that directly include community stakeholders. I think that one of the real benefits of including the community as part of the strategy designers is not only does it build consensus, but it also helps to craft communication in a way that is really appeals to a cross continuum of community members so that everybody has the same level of understanding. Because in those kind of boots on the ground research sessions, you can course correct if something's unclear in the way of a specific model or a specific relationship between variables that relate to infection, infectious disease, and climate change. And it also helps you to identify perhaps at-risk or disenfranchised communities that might not necessarily be on the radar based on just the objective data or the initial data that you have. So I think that's a really critical component that we need to continue to expand in research on climate change, social equity, and community health.
And I have a question for Sadie. Obviously, we'd be remiss to not think about some of this work in relation to COVID-19, to the pandemic that we're all experiencing, even if this is not the central subject of this conversation. But I want to ask if there are any issues that have sort of come up in this pandemic, or ways that this pandemic has changed the shape of the conversation for other vector-borne illness, and the kind of work that you do, the kind of work that you presented on, and anything in mind that you would, I don't know, like to sort of, any approach that you would like to keep around after the pandemic is over?
Well, I mean, obviously, things like going out and doing field work in international settings has been severely curtailed for a while. And so it's been interesting to reflect on sort of what happens when people are stuck at home. And a lot of what people in the US have done is started taking walks near their houses. And so early on in the pandemic, there was this question about, are people suddenly changing their behavioral exposures to things like vector-borne diseases? Are people who wouldn't normally go for walks in their neighborhood, now getting exposed to maybe, the vectors of their neighborhood and not thinking of themselves as people who are walking outside in nature and therefore don't do things like tick checks right away. And so is there, is there a room for getting a bit more of the public health education about how to sort of do, self-care prevention of vector-borne diseases? And I think that was sort of, something that in the Northeast they started to notice was something they wanted to think about a bit more. And I think, sort of in Florida, we started to think about people being in their peri-domestic environment. Maybe they're now paying more attention to things like those mosquito breeding habitats around the house because they're stuck at home and they can see them. Or maybe they're not. Maybe they're now being exposed more to it because they all want to, maybe go outside and adjust their landscaping or something like that. And so there's sort of this question of how much has individual behavior shifted sort of risk of exposure in the presence of another disease. And so are you getting these sort of almost syndemic effects? That's, when two diseases are going on at once that are kind of pushing people into a different risk space. And I think that's really interesting to think about. And it sort of elevates our awareness of the fact that there's multiple factors going on here. Another sort of less fortunate thing that happened was that because a lot of vector control districts are in the same budget as any district control agency, that things got shifted, right? Budgets got moved, people's jobs shifted to other activities. All of a sudden, people were on COVID teams. And so the worry there is that there might be a reduced sort of effort in surveillance simply by virtue of people being moved to other posts in their same agencies. And so that, that will be something we find out more about in the future, what kind of impact that might have on data streams that we, want long-term consistent data streams. And perhaps there's less sort of awareness of, if something novel is popping up, it might take longer for us to know that if there's less surveillance going on. So these have all been concerns. I haven't seen, actual evidence of all of this yet. And I think a lot of it will be in hindsight. So I think it's a good question to sort of think about what a COVID lens is on a lot of these questions. Thank you.
Yeah, from my perspective.
Go ahead, Naresh.
Can I add a little more thing? I think the COVID-19 is a great learning experience for us. We adapted dramatically to these dramatic changes that COVID-19 forced us to. It's the similar thing with regard to climate change. The difference, however, is that climate change don't show up that dramatically. It doesn't kill you within 3 to 5 days. Think about the infectious disease burden that we talked about, or asthma burden we talked about. They are long-term, they're imperceptible. But if you can convince people these disease burdens are tied to many of the things, we have the ability to tune and adapt to these climate changes too. But we are too short-sighted and we don't pay attention to those things. So for me, I think the adaptability lesson that you can learn from COVID-19 is the most significant one to deal with the health effects of climate or societal impacts of climate.
Yeah, thanks, Naresh. And I want to stick with you and talk a little bit about prioritizing health equity and justice in this context of climate change. And so as a researcher, like for you, what are some of the challenges of developing an evidence base to demonstrate the inequitable health effects of changing climate and the associated healthcare costs?
Right. So as Darren was saying, that one part of my research is to bring real-time information to people. And what does this mean is simply many of the children that we're recruiting from our clinic who are pediatric who have asthma. That's the first condition. And secondly, they have allergies. And in addition to this, I have another study in which what happened was we deployed these hundreds of sensors in their home. They're still streaming data. And all of a sudden, one of the pollutant that the sensor picks up, the ammonium chloride and ammonia. And as you know, many of these cleaning products do have ammonium chloride. So people started using ruthlessly these very strong chlorine-based products like Clorox and bleach, and indoor pollution began to suffocate. So to answer your question regarding the equity, if you can give this information to people, telling, hey, your indoor air pollution. Your ammonia level in the house is relatively high. If you're using these cleaning products, you need to ventilate your home. Otherwise, don't use, or use some classical, for example, vinegar or baking soda kind of products, which are more friendly, though don't react too much to your airways. You can manage this asthma. So in order to address the equity, people need to provide it with the information, real-time access to information related to climate, weather, and or the environmental pollution that are exacerbated due to climate change. So once you do that, people can take action. When information is popping up in your face and saying directly your asthma, that your child's asthma is exacerbating because of this, you will take action. So for me, I think the key, real-time access to information, which makes a difference in people's life, that will make a significant impact to deal with equity and justice.
Yeah, thanks, Naresh.
And kind of going back to Sadie, your presentation, you mentioned, or you alluded to like business as usual. And I just want to ask, maybe like very high level, if we stay on course in our state of Florida without a transformation of the ways of the communities engage agencies, that agencies engage researchers, how do you imagine these matters impacting different populations differently in the state of Florida in terms of equity?
So, I mean, one concern that I've heard that I think is more pressing than people are perhaps aware of is the sort of so heat is increasing in all these climate scenarios. We know that, but heat impacts people in different ways, and it impacts different sectors of the populations in different ways. And so, you know, when we see forecasts of things like how many more days are going to be above 95 degrees, for example, that is really too hot, right? And if you have air conditioning in your house, you can mitigate that. It's going to cost you more, and so that's a cost. But if you're, for example, an agricultural worker exposed to these heats outside, or maybe you're in not great housing as an agricultural worker and you can't mitigate that heat, so you can never bring your body temperature back down to safe levels, there's going to be all these knock-on effects. And so I think as we sort of see climate changing in Florida, you know, it's going to be the extremes, and it's going to be, you know, more stormy. So we're going to see lots more sort of storm impacts. We're also going to see different impacts of that heat impacting, and I keep saying different people in different ways, but you know, it's definitely got different levels of vulnerability already built into occupational structures. And so that creates inequity that isn't simply sort of transferable onto socioeconomic landscapes. So one study we did recently looked at this question of how populations themselves will change through time, sort of projecting the demography of these different occupational sectors and different age class sectors through time, and then where that intersects with vulnerability to, in this case, it was dengue suitability for how many months, and sort of saying that there's, you know, there's definitely going to be a shift in how different parts of the population will be exposed differently with climate change. And so that speaks to sort of the data behind potentially discussing equity issues. Obviously, I'm not on the policy side of things, so I wouldn't know, you know, how you would flip a lever, as Lisa might do, to say, how do we address these sectors of work, you know, work categories in occupational situations versus different age classes, which may be more of a clinical side question that Naresh would be approaching. So I'll stop sort of elaborating on that, but hopefully that addresses some of this question.
Thanks, Sadie. We're going to wrap up here in a minute or two. This has been amazing, but I want to just finish up with a final question to you, Lisa, about how your research using predictive frameworks can actually inform policy and help decision makers to work towards equity and justice.
So thanks for that question, Jason. That's one that's near and dear to my heart. I think one of the things, and Naresh touched on this, and Sadie has mentioned it too, is that whole communication sustainability issue is really important in policy formation and community health improvement. And one of the things that predictive models have the ability to do is kind of span that ugly middle when everybody has improvement fatigue, because oftentimes communities or policymakers will institute an improvement and not see immediate results in terms of population health improvement or public health responsiveness. So that's the benefit of using, as I mentioned, even theoretical data and these predictive models that I love that George Box quote that all models are wrong, but some are useful. And it's really apt for this particular situation because it allows people to basically understand, hey, if we institute an improvement, we might not see results for 18 months or 2 years, but we will after that. And then the improvement should be, at least hitting a tipping point. And so it allows people to kind of hang in there while they're instituting community health improvement initiatives. I hope that answered the question.
Yes, thank you, Lisa.
Absolutely. And I just want to thank all of you watching and everyone here for this conversation. We've been talking about climate, health, and equity. And again, we'd like to thank the Florida Climate Institute for organizing this event, along with the sponsors, the Florida Sea Grant and the UF Office of Sustainability, partnering with us at Disasters Deconstructed Podcast. And of course, a special thank you to our wonderful panelists today, Dr. Sadie Ryan, Naresh Kumar, Lisa Platt, and thank my co-host, Jason.
Thanks, everybody. Have a great weekend.
Thank you, you too.
Thank you. Bye-bye.